Good morning, everyone, and welcome to the third webinar in our series about evidence generation for digital health. We're delighted that you have taken time to register and hear our panel today. In today's webinar, we're bringing together three leading authorities in the field of mental health, all of whom have extensive experience of developing, implementing, and researching digital mental health innovations, including those developed recently in response to the COVID-19 epidemic. My name is Paul Wallace. I'm an academic GP by background, Professor Emeritus of Primary Care at UCL and Clinical Director at the South London Academic Health Science Network, the HIN. I'll be co-chairing this webinar alongside Dr. Jean Ledger and Professor Henry Potts from UCL. The series is brought to you as a collaboration between UCL, DigitalHealth.London, MedCity, and the Health Innovation Network. We're going to be chairing a discussion with our panel for approximately the next 30 minutes, leaving time for a Q&A and engagement with you, the audience. Please write any questions or comments you have for our experts in the chat box, which Jean and Henry will be carefully monitoring. And we'd encourage you also, if you can, to use Twitter and hashtag #EvaluateDigiHealth during the session. Today we have Professor Dame Till Wykes, Professor of Clinical Psychology and Rehabilitation at King's College London, an acknowledged leader in the field of mental health research. We also have Dr. Sarah Carr, Senior Fellow in Mental Health at the Institute for Mental Health in the University of Birmingham, who is both a researcher and someone with personal experience of mental distress and mental health service use. And finally, we're delighted to have with us as well Dr. Dan Rowbottom, who is the Deputy Research Director at the McPinn Foundation, a mental health research charity that actively involves people with lived experience of mental health problems in research, including digital mental health interventions. So welcome. I understand we have about 140 people signed up and hopefully logged on to this seminar, and I hope very much that you're going to find it interesting. I'd like to begin by asking each of our speakers just to give us a very brief 2-minute summary of how each of you have been involved in digital mental health in recent years and the types of studies you work on. So Till, if I may, I'm going to start with you.
Okay, well, I'm a jobbing clinical psychologist and a professor of clinical psychology as well. And my research has mainly been involving service users in this particular arena. So I do a lot of different kinds of research, but in this arena, I was really looking for digital applications that were acceptable, feasible, and effective for people with mental health difficulties. So I've published quite a lot in this area, but I've also had some useful thoughts, and certainly I have opinions now. Most of them, I hope, evidence-based.
Thanks very much, Till. And Sarah, would you like to introduce yourself?
Sure. I'm Sarah Carr and I work at the University of Birmingham. I have a background as a mental health service user, and I also have an academic background in mental health social care and policy. And one of the things I'm concerned about is policy implementation and evidence-based policy as well in digital mental health. I'm concerned for it as a potential user. So I like to focus on patient and public involvement in research in digital mental health applications. And as an extension of that, I'm very concerned about the ethics as well as the effectiveness.
Thanks very much, Sarah. And I think those themes are going to come through the discussion very much today. And finally, I'd like to ask Dan if you'd like to introduce yourself.
Thanks, everyone. Thanks, Paul. My name's Dan Rowbottom. I'm from the McPinn Foundation, the research charity based in London, working in mental health area. So my interest in the what we might call digital health broadly focuses on various areas. So for example, I did some research in the past around interfaces with clinical records and apps and things like that. I'm very interested in the idea of digital exclusion and inclusion, and who is being left behind, particularly as we move forward to this sort of remote office working environment. I'm also interested in the ideas of data privacy and who owns the data and where it goes, for example. And I've been involved with designers and developers in helping working with people with lived experience to develop and design some of these interventions as well.
Thank you all very much. I think, as you can see, we're lined up for what I hope promises to be a very interesting discussion. I'd like to kick off with the first area of questions and discussion, which really is about the impact of digital technologies, digital health technologies on mental health services, particularly hastened by the COVID-19 pandemic. And I wanted to ask each of our panelists what areas of mental health care they have seen being most impacted by the introduction of digital technologies and how. Till, can I ask you that question first?
Well, clearly the COVID pandemic has affected all health services, not just mental health services, but perhaps mental health services have been most affected because we rely much more on face-to-face communication. And particularly because when we talk to people, we assess their mental state, how they're feeling. And if you can't see them, it's very difficult to do that. But even when you can see them, like you can see me now, or at least head and shoulders, you can't, I could be talking and trying to evaluate somebody over Teams or Zoom here or over Skype, but I won't really know if they're very anxious because I'm pretty anxious. My knees could be now jiggling up and down underneath the table, but I wouldn't be able to see that. So that really affects the how we can gauge difficulties of someone. It's very difficult to think of a particular service that has been affected. Every one of those outpatient appointments has been affected because of this face-to-face issue. We've, as Dan was talking, we've managed to overcome some of this with Skype and Zoom, but still some people want face-to-face. And partly that's because either they don't have a place to talk about sensitive information in their house, or they may not have the skills to be able to do a Skype or Zoom call. I know I didn't when I first was locked down at home, and I ended up shouting at the computer because I didn't know what was going on. I've now overcome some of those challenges, but they are challenges, and if you have got mental health problems, then that's going to be even more of a challenge to you. And you may also not have the right technology or the right good internet at home. So it's very difficult for some people to overcome that. Although we have had some good things come out of it. So we've accelerated in my trust, that's the South London and Maudsley NHS Trust, we accelerated the implementation of an app called Beth, which puts people in touch with between service users and the services, which actually people have begun to use much more because it's a case of having to do that. And that has been quite a useful thing. So although there's been some impact of the pandemic, which has been potentially negative, we don't know how many people we've excluded, we also have had some benefit by an acceleration of technology use, which may, who knows, may prove to be useful.
Thanks very much, Till. Sarah, can you give us your view on this and perhaps, again, particularly think of an example where innovation of this kind has been or perhaps could be welcomed?
Yeah, in the situation of the pandemic, we've seen sort of a rapid increase in things like remote working, over Zoom, telemental health. as Till's reflected. And this seems to be working for some service users and practitioners. And some service users have said, well, you know what, we've been asking for this for years, and suddenly it's happened, and we've been told maybe there'll be difficulties with it, but here we are. So for some people who use services, this has been a good thing. For others, not so good, because again, as Till says, the medium, the remote working doesn't always adequately support some of the communication. And the therapeutic relationships and the non-verbal communication that can be recognised in a face-to-face environment, and also people's where they're living can be cause some difficulties maybe. So at the Institute for Mental Health at the University of Birmingham, we particularly focus on children and young people. Now, telemental health, where the child or the young person is speaking to a therapist or a psychiatrist in the context of their own home, where they might be living with their families, this might prove to be problematic or inhibiting if they haven't got the requisite amount of privacy, and maybe their family or their familial situation, parental relationships might be something they need to talk about. So I think there are some pros and cons. Obviously, the government is very keen on implementing more telemental health, more digital health technologies in mental health, but there are concerns about how much that will, quote unquote, take over from the face-to-face human interactions for various reasons, some economic. So I think that's something that we have to keep an eye on. But the pandemic situation as a kind of not exactly a test bed for remote and digital technology is interesting, and I think there's some research going on about it now.
Thanks very much indeed, Sarah. And I think, again, really important points. You've talked about the issues of privacy, and I'm sure we're going to come back to that. And of course, one of the things that we want to run through this discussion is around evidence, and the evidence that these things about how they function. Dan, again, I'll ask you the same question from your perspective, the influence of COVID, and perhaps if you can tell us about a digital innovation that didn't work so well and why.
Thanks, Paul. I can certainly answer the first part of the question. I think just echoing what other people have thought. I mean, I'm quite interested, when McPin as an organisation, I suppose, evolved, if you like, from being a predominantly office-based organisation to predominantly an organisation of home working, at least for the time being, then we I suppose, spent quite a lot of time sort of trying to get our house in order, trying to figure out how we needed to exist and how we needed to work with each other as a team and, as a wider team across the country. And then it sort of came evident to me that, that who are we missing? Who are we not seeing on a regular basis? Who's not turning up to our meetings and groups, and, and is there anything that we have to do to try and sort of help include them, include people? What are the barriers to people's inclusion? Is it because they haven't got broadband, or and various different scenarios? And what I'd like to see more of, I think, as we go forward, is lived experience based IT and tech support in NHS trusts. I think we're going to need in our own organisation, which is different, I suppose, from mere tech support in a generic context. So people who can talk to people who can sort of understand some of the issues that people are facing, and design tech support around that in a kind of friendly way. And that's kind of what I'd like to see. And coming on to your second point, I think that the reason why digital interventions have not worked well in the past, in many instances, is often because they're not really designed for the people they're supposed to be working with, working for. They're designed in a way which is too technical, or they're solutions which are looking for problems. And I think, you know, with COVID-19, we've very much got a problem which needs solutions. So maybe this is a sort of watershed moment, really.
Thanks very much, Dan. And I think, you know, some important themes coming through around privacy, technology, the digital divide, and the need for co-production, particularly with mental health apps. I'd like to move us, if I may, into the second area, which is specifically the reflection of the title of the webinar today, Factors Engendering Trust Amongst Users with Mental Health Issues. We have a sort of sense of what might be those factors, including usability, safety, data privacy, confidentiality, perhaps effectiveness. What does research tell us about these and other factors in engendering trust amongst digital health users with mental health needs? And I'd like to ask Sarah first to respond to that.
Basic level, a confidence and trust in digital technologies and what happens to the data that's being collected. They're absolutely core issues for the public. And of course, people with mental health problems are members of the public. I think in terms of the general picture, there's currently quite low trust in digital and the use of data. The most recent example being test and trace, where serious errors can cost and curtail lives. So I think we need to wind back to the basics of gaining public confidence in digital technology and data collection. And the latter is of concern, I think, to many, because digital technology can be used to collect data, to then train AI to support decision-making, which predicts future events. So in this case, a mental health crisis and a relapse. And in terms of trust and confidence, are we okay with this possibility? Are we being asked for our opinions about this? Questions about who have control over decision-making in the mental health system, that's quite frankly, you know, still characterized by some power imbalances, the ideas of coercion and compulsion, and how will consent be conceived and sought, so for data use and treatment. So there are some difficult questions about motivation and context and implications that need to be asked before any research begins. So people really need to be kind of clear about that and be involved in conversations about that. So that's the public, but particularly patients and service users and their families as well. So having those conversations about the ethics and the implications before we even start the research is vital.
Can I ask you, thinking about the evidence generation side of that, what are the best ways, do you think, of ensuring that development and evidence generation do take full account of these? I mean, I think what you're saying is patient involvement is absolutely, or user involvement is critical.
Yeah, absolutely. And sort of just going back to what I said, patients really need to be talking with clinicians, with the institutes and organisations that are undertaking research into digital technologies for mental health. We need to be asking about the ethics, about the context, and need to be devising the questions together and thinking about what methodologies would be best in the research. So, you know, you might have clinicians who are very interested in measuring things like the effect of, say, a monitoring device on symptoms, on behaviour, but for service users, they might be interested in something very different. So we need to bring those two people together, those two groups of people together, to agree on what measurements and what impacts would be most helpful to measure in terms of generating evidence there. So public and patient involvement right at the beginning, and not just on steering committees after all the decisions about the research has been made, because, you know, you can find out in clinical terms if an application is effective But if service users and patients aren't going to use it because they don't trust it, or that it doesn't measure what's important to them, we have an issue with uptake and adherence.
Thanks very much. And we will come back, I think, certainly to the issue of co-production in research design. Dan, I wanted to ask you to reflect on this, and particularly one of the things that I've reflected on is that when we're dealing with pharmacological research and pharmacological products, people starting a new pharmacological treatment are provided with a drug information sheet. What do you think should be the equivalent for patients starting to use a digital mental health application?
Thanks, Paul. I think this is, from my experience of talking to people and running lots of discussions over the years with people with various different sort of mental health experiences over, around this area. I think what comes up time and time again is, yes, I think there is need for information. I think people are interested in what these digital health interventions do. Obviously, who makes them? The NHS, we're in a very obviously an interesting period in history. The NHS has a badge to it, it has a kudos to it. And if something has an NHS logo on it, then many people will just respect it and assume that it's going to be well done, etc. I think obviously the test and trace does bring this into light a little bit, but I think it's not. It needs to be obvious who's making the intervention, where's the data going? Is it going to build some algorithm somewhere? And I think a lot of this comes back to who owns what. Not everybody knows that YouTube is owned by Google, for example. And there's lots and lots of different apps out there that may start off as sort of well-meaning small businesses, but as we've seen, they often get bought out by others. So it's understanding those trails of where data is likely to go and who's likely to have what is very important. I don't want to labor this point too much, because I know there's some people are very interested in the idea of privacy and other people really don't mind. So it's a real divide in that sense. I think what is important is, again, another thing that comes up is around linkages. So where is that data going to link to? Is it going to be linked to my health records, for example? Is it going to be linked to the job centre? Is it going to be linked to criminal justice records? There's all these kinds of questions that come up when you start thinking about apps and about where that data is going to go to. Another one, of course, is around health insurance. Is it going to get health insurance going to get access to my records? So I think good GDPR data management, including as a user of these things, do I have the right to be forgotten? As GDPR would seemingly allow me, does it all check out, and is it going to be helpful? I mean, they would be the main things that I would ask, and they're the main things that come to mind when I've spoken to others about these issues as well.
Great, Dan. I just wonder, I think so clearly your main concern in providing patients with information is for them to know where it is that their information is that what they enter is going to end up. Is there anything else that you would pick that a patient being offered with an app like that would want to absolutely know? Clearly, that's a very major issue.
I suppose whether it's going to be helpful, what the technical requirements are, what you have to own in order to be able to run an app. Obviously, not everybody owns the equipment. Whether it's been who else has used it, who's recommending it? Is it a doctor, a health professional? Is it someone that they trust, or a peer? Often apps are spread from peer to peer. And said, oh, this is a helpful one, try this one. So I think those sorts of things are as helpful as what can be written on an information sheet, if you like. It's the kind of informal networks that that spring up around these kinds of interventions.
Thanks very much. Till, thinking about the same area, what kind of recommendations do you think should be made about the evidence that clinicians and commissioners, rather than patients, should require in order to enable them to make informed decisions about adoption and implementation of digital mental health innovations?
I actually don't know that there's a lot of difference actually between what service users want to see and what clinicians might want in terms of whether they prescribe an app. So one of the things that is really noticeable about most apps, well, all apps actually, is that until you download it, you don't get a lot of information. So it's a bit weird because, you know, when you go to the supermarket and you want to choose a box of cornflakes, you can look at the different kinds of cornflakes and you can look at the back of them and you can look at the ingredients and you can make a decision about whether you want to have, you know, a particular kind of cornflakes. You can't do that with an app. If you look at mental health apps, there's, I think 75,000 were added last year. So what we really need is, and something I've written about before, which is the transparency for trust principles, which is where there is information available in the App Store or in the Play Store, which will tell you something that everybody needs to know. So there are places like I am on the scientific advisory board of One Mind Cyber Guide, which does do reviews of apps and it looks at effectiveness. And it also has now developed a service user rating for the app rather than those stars. But if you're going to use, if you want to look for an app, you have to go to two places. You go to the App Store and then to the One Mind Cyber Guide, which is a charity. But you don't want to do that. You want to go to the App Store and look for all of that information. And I think in terms of effectiveness, the one thing that I think people really need to know, I mean, they need to know how it's developed, how much time you need to spend on it in order to get a benefit. You need to know how many people did not benefit. A clinical trial gives you a significance of whether there is an improvement that's clinically significant. But that doesn't mean that every single person who uses that app will get an effect. And usually it's at least 25% of the people who use the app will not get a benefit. We need to know that because we need to say to people, if you don't get a benefit, maybe you're just one of the 25% who didn't receive a benefit. And that's really important because these are people with mental health difficulties who actually, who already may feel that some failure. So the idea of giving them a treatment, which it says this is wonderful and it works for everybody, and it doesn't, will make them feel even worse about themselves. So that particular bit of information, I think, is absolutely vital. It's not the number needed to treat. It's a very simple number that everybody can understand. And it's not true that everybody can understand everything on an app because we're just doing a study on the privacy policies, the terms and conditions, where it's some of the apps you need a university degree to be able, or even to have your lawyer sitting next to you to understand what's written in the privacy policy.
Thanks, Till. Very, very interesting points. And I guess it takes us in a way into the next area, which is around co-design for digital health development and how to ensure that the patient view is incorporated. Dan, I'll start with you. You've had a great deal of experience of doing research and evaluation with people who experience mental health difficulties. It's part of what McPin does. What do you find to be the main challenges of involving people with relevant lived experience in evidence generation, and how can they be overcome?
Thanks, Paul. I think the Probably the main one is getting some sort of synergy between what the app developer wants to achieve, what the clinicians want to achieve, and if they're relevant in a particular case, and what the person who's going to be using the technology wants to achieve. And these are not all the same things, although they should be. They're not all the same things. So having decided, got that agreed, the next challenge, I think, is finding the right people to test it out, rather than just getting people who are the most tech savvy or the most kind of, I suppose, the low hanging fruit, if you like, to test out digital interventions. Sort of going for people who are kind of the middle ground, people who may use the technology, but probably wouldn't necessarily rush to it, not necessarily early adopters. And I think a lot of the problems comes with immediately just assuming, finding early adopters, or just making assumptions that the only people that are going to be interested in digital health are going to be sort of young men, for example. These are, I suppose, assumptions that don't really work in reality. So getting a broad range of people who are going to be potentially interested in using the app, but who are not necessarily going to rush towards it as early adopters, and then working with them over a series of meetings with the app developers, program developers throughout. And I think one of the things that we did in the Game Change project, which is led by the University of Oxford, it's about virtual reality interventions for people with psychosis who avoid social situations. And the idea is to develop virtual reality scenarios whereby people can test out social situations without having to do them in reality, as kind of like warm-up, if you like. And this involved working with the designers, and it also involved working with the Royal College of Arts. And I think there's a sort of an unwritten issue here, which is that there's something in the design field that I didn't really know about until a couple of years ago, called user-centered design, or UX design. They use a slightly different terminology and language to what we're used to in mental health research, where we maybe talk about PPI, patient public involvement. And I think it's marrying those two things, which are slightly different. And that's really what one of the key things. But it can work really well, as it did with our Game Change PPI, with our Game Change development.
Thanks, Dan. Till, you've published widely on public and patient involvement in research and development in mental health. And you've mentioned briefly the transparency initiative that you started. What are the key messages that you would draw from your work?
I think it's similar to Dan, actually. One of the things that tends to happen is that, well, this is the bad way that apps are developed, but the most often used pathway, which is that some bright spark in a startup has an idea. They produce some kind of wireframe and formula for the app. They may ask a clinician to have a look at it and see if it follows some kind of principles. And then they may do some beta testing before they launch the app. But the beta testing is with university students who are slightly stressed. And then they advertise it for, well, actually, most of the time they don't say it's for depression, but it's clearly for depression. They most often say this is for well-being. And the reason they say well-being is it gets them out of having to go to the regulator. What should happen is that there should be a discussion from the beginning with the people who are likely to be the end users to develop an app which they can engage with and which they may well use towards the end. So there needs to be, as Dan was saying, user involvement throughout. the pathway, because if you don't, you end up with an app which, you know, gets launched and it's a red app on a Monday, and then a similar app, but it's a blue app, gets launched 2 weeks after that. People download it. The data, your data, is used. There is no such thing as a free app. The only way that an app company will make any money is that your information is forwarded to, in the background, to some marketing people. And that's why, for instance, you know, suddenly I've got adverts for slippers on Google, which I think I've never actually used, bought a pair of slippers, but you get these things being timed at you because of the way that people are using your data in the background. So I honestly think that it's really important to develop these transparency for trust principles, but also to adhere to them in the user experience. So you start at the beginning by developing the app with the people it is meant to cover. And that also means that you don't translate it from an online therapy. We use apps completely differently to online therapy. We use them in different places. We use them for shorter periods of time. And the effectiveness data from online therapy cannot be transferred to an app. So it's also that you need to develop the evidence base for the thing that you're selling, rather than using other information.
Very important point. And thanks, Till. Sarah, coming to you, as someone who's not only a researcher, but also who's experienced mental distress and used mental health services, what are the aspects of research and development that you feel the patient voice can provide, or where you feel the patient voice can provide the greatest benefit? And perhaps can you give us an example where patient and public involvement or lack of it has made a significant difference?
Sure. I mean, I agree with Till and Dan here, and particularly the idea that patients and whoever else has an interest in the application or intervention from the user perspective should be involved or should be co-designing it from the very, very beginning. And I've talked about the questions that need to be asked about ethics and applications and implications, but also, you know, there needs to be basic questions asked of the end user. You know, what sort of application do you want? What would be useful? How can we support the design of that? Because there is some research to show that, you know, you get people dropping out because for various reasons. One of the things, it doesn't really work for them. So I think that having that involvement right at the beginning, from conceptualization stage, you know, asking people, what do you want? What might work for you? And then people who are involved in the technical development, helping realize that idea. In terms of testing for effectiveness, absolutely people need to be involved. Like I said before, there may be things that service users want to measure, the outcomes that are important to them. That needs to be captured in a study, probably in a mixed methods way. And also, you know, what Dan said, getting people involved, not who are just enthusiasts, but people who need to be convinced, people who maybe you could put them into the group of people who refuse or don't feel comfortable with using things like digital mental health, tele-mental health. And who can pose, you know, questions, who can throw up problems. And as part of the research process, you need to do some problem solving. But I wonder if the type of involvement and co-design that will go on, if it's happening with people who are working in technical development rather than just clinicians, we might get a different dynamic as well there. And just one other thought on that. One of the things that we were talking about earlier is the idea of information sheets and people being fully informed before they use something. One of the things that PPI and in the co-design could support is looking at some of the adverse effects, the potential side effects, and measuring those. So people have enough information to make a choice as to whether or not to use this thing. So somebody, like Till said, you know, it may provoke anxiety or rumination if you're having to, particularly for mood trackers and those types of kind of applications. It may not be great for the person to keep thinking about the mood.
Yes, and I'm very glad that you brought that up. So really interesting discussion. I think some real clarification. I suspect members of the audience are going to want to pick your brains about specific aspects of that. And we're very close to being able to hand over. I just wanted to dedicate the last 5 minutes of this panel discussion to a more sort of generic question for each of you, just very briefly. I wonder what you think about bridging boundaries in this very rapidly evolving field, and whether you think the different communities, researchers, policymakers, tech companies, and as we've been talking about, patients and patient groups, are actually talking enough to each other about the evidence underpinning digital mental health technologies. And if not, do you have any final reflections about how that could be achieved, how better co-working could be achieved? Till.
I have a lot to say, but I'll try and make it brief. You know, I really think co-production is essential, and it's a win for everybody, because if you end up with a product that's useful, that people like, then you're more likely to be having it being used much more. You might even sell it to the NHS as one of the recommended apps, because there's a few in the NHS app library, which will actually mean that you'll make a lot of money out of using this app. So for the developers, I think they will end up with a product which will be used. And I think that's absolutely vital. But I do also think that there's an issue about power in this as well, in that we've got to take into account what service users want. And I think we started at the very beginning talking about the loss of face-to-face communication. And what service users often say is that we don't mind using an app, but that doesn't mean to say it takes over from the face-to-face communication. And I think that we're sort of going in the wrong direction, thinking we're going to have these independent apps. I think Sarah said earlier that what the government thinks, and certainly Matt Hancock, is that if you have a digital tool, then you won't be putting any pressure on the mental health services because you won't be using them. Whereas I think that digital tools are about blending therapies. So having face-to-face therapy and an app maybe can be used for homework in between sessions, or it can be used as maintenance treatment. So the two should be brought together rather than thinking about it all as being independent of any mental health service.
Yeah, I think that whole point about blending applies actually to the whole digital field, and a very important one. Sarah, any thoughts about how this could be improved, the co-working of different stakeholders?
Well, I'm going to come back to sort of something I've been banging on about throughout, is the idea of having some agreed ethical frameworks that are co-created, and that should include people who are working in the private for-profit sector, tech companies, who are doing a lot of this development and who aren't necessarily subject to the same kind of ethics and ethical scrutiny as, say, universities are. And, you know, clinicians need to be involved, policymakers need to be involved, and of course, patient service users and carers. I don't know how we would handle or gather those people together, but it certainly needs to be done. And before the research, we need those ethical frameworks. I agree with Till that there are power dynamics at play. There could even be vested interests. So this is another situation where we need to build trust and transparency and understanding between the different stakeholders, and particularly those who are developing such technologies. So, the other thing that occurred to me as we were speaking, and something that probably needs to be raised around, if we're thinking about bridging boundaries, are some of the boundaries when you're designing apps that are more focused or aimed at people maintaining well-being, rather than those who are living with long-term conditions, have experiences of psychosis or bipolar disorder, or enduring depression. How does that work? Are we assuming that well-being apps will work for people with these more kind of long-term conditions? So I guess that's another boundary to be bridged, and something else to be discussed.
Thanks, Sarah. And Dan, forgive me, but I would like, if you don't mind, to pass now to the to open this up to the audience. And I'm going to hand over to Jean, with or without Henry, to give us a flavour of some of the questions that are coming in. But thank you all very much for your views as a panel. Jean and Henry.
Hi, thanks, Paul, and thanks to all our panelists. We've had a very active discussion online, so we're very grateful to everybody who's been putting comments, and there's been a lot of papers that have been shared. Just going to pick up on a few key issues, and I'll address the questions to people individually, because we may not have time for everyone to answer these. There were some comments really about positive examples. Have you seen some examples where we can really, people are embracing the opportunity of digital health, and there's really been some positive user engagement, such as we've been talking about, and really positive user-driven applications for digital mental health? Maybe if I could ask that question to Dan.
Thanks. That was one of the things I wanted to finish up on. But yes, I think one of the challenges, I suppose I've got 2 points, and I'll be quick. So my first one is around, I think we should think very broadly about what digital health means. So digital is just the transmission of a signal that isn't an analog signal. So when analog televisions went out, they switched the analog TVs off, and anyone who had an analog TV therefore couldn't watch TV. So we just need to be mindful of what digital actually means. So I would include Zoom as a digital mental health intervention, if to be honest, because you can do it electronically, etc. So I think there's lots and lots of examples of digital mental health out there that we wouldn't necessarily think of as being that. I really like this idea of, because I think the way forward for some really interesting developments would be around getting communities of interest together. So people with experience of mental ill health, who are coders, who are carers, service users, ex-service users, clinicians, and actually doing what they do in the tech field, which is sort of hack days, and adapting that for this context. And I don't think that's done enough. I think that too often it's like, okay, here are the coders over here. But actually what you really need is coders with lived experience of mental health issues, who are therefore bringing that into their work. And the similar with the evaluation and research of these things too. And I just thought I want to make that point. I don't have any specific examples of that actually being done, but I think that is the way forward for me.
Thanks, Dan. So that's really a kind of a call to the community. If anybody wants to set up those kind of interactive bringing together of different stakeholders to actually develop solutions, maybe we could see more of that in mental health. The next question is really about the kind of marketplace for all these apps, and we've got lots of companies making different apps. I mean, is it better to have the choice in this market with all these different developers making different solutions, or actually do we need to be kind of narrowing the apps into a kind of cohesive platform for mental health users to access? So maybe you could have a go at answering that question.
Yeah, I totally agree. It's a confusing and increasingly crowded marketplace. Just and to go back to what I just said about, you know, a lot of the apps that are available kind of, you know, quite widely are to do with well-being rather than you know, hardcore mental health management. What I think would be helpful is to have some kind of standard for quality, and some transparency around that, so people can make informed choices about which apps to choose and use. So that could, as I say, could include some of the benefits, some of the potential, you know, disbenefits. Not, I hesitate to say harm, but yeah, having the right information to make choices, I suppose, and some of that would need to be evidence-based.
And do you think, because it came up earlier about NHS and branding, do you think for mental health service users, they would like to see things being promoted by their mental health services and providers, or should they be, you know, is it better to have an independent platform? Do you have any views?
Yeah, I mean, there are pros and cons to having NHS branding, particularly in the light of what's just been happening. Some people will trust that more than independent things, but I think, again, having some kind of standards that apply to both would be helpful to enable people to choose. I was involved years ago looking at some kind of therapeutic sort of project, but the project took place in companies and corporate environments. It was a mental health and well-being kind of program, but this mental health and well-being program was investigated with people who are managing long-term mental health problems. So it wasn't just a well-being thing, and because that particular program didn't function in traditionally clinical ways. It was developed outside the mental health services for a different context. People did respond quite well to it because of that, because it wasn't associated with conventional mental health services that they might have had negative experiences of.
Thanks, that's really, really helpful. Lots to think about there. Just a final question for Till. We've identified lots of, we've spoken about telehealth and apps. Are there any key areas in mental health digital provision where there are some gaps at the moment? Are there some unmet needs where you think more work needs to be done, either in terms of the research or developing solutions? Anything you've picked up on in your career so far?
Well, I think both Sarah and Dan have mentioned a couple, because many of these apps are for people who are well, it's described as well-being. It's not actually for people with mental health problems or difficulties, and I think that requires a different kind of development that looks very carefully. I think, as the first question you asked was should we get people together? The problem is what clinicians want and what service users want is often different. And we're going to have to deal with the fact that there's a difference between them and somehow help to negotiate that space. And I think that's really important. But there have been good examples. Blue Ice is an app which was developed with service users for young people with depression. All data was held on the phone. None of it went anywhere else. You could delete it whenever you wanted. And it had an evidence base. However, it wasn't funded from, it was funded from within the NHS. It's available only within the NHS. And the difficulty is, because it didn't have a market, it hasn't been marketed properly. And I do think that, 75,000 apps a year put onto the App Store is not helpful for people with mental health problems, which is why One Mind Cyber Guide has tried to help people work their way through these apps, because some of the rating scales that people have used are not useful for clinicians nor for service users in making a decision about which kind of apps to develop. So I do think we need people to be more thoughtful about what they're doing. Clearly, these companies must be making money because otherwise they wouldn't provide these apps. But I do think that for the NHS, we need to have apps which can help people either in a blended way or can help people who have more severe mental health problems to use them and get a benefit. And what we don't know at the moment, because lots of companies say, oh, we can't do an evaluation, we can't do a randomized trial. Well, why not? There's no reason why they shouldn't do that. So there's a big gap for the apps that are in the App Store, because most of them have very little evidence for whether they provide a benefit.
Thanks, Till. And for everyone watching, we covered some of the regulation points in our first webinar, which will be made available for on-demand viewing soon. So lots of questions in the chat about regulating this space. So I'm going to hand back over to Paul, and thank you everybody for your contributions.
Thanks, Jean. Thanks to Till, Sarah and Dan, I think, for a really fantastic session, and indeed to all of you in the audience who've contributed both online on the chat. I've had a chance to have a quick look at it in the last few minutes and to hear the questions. I've certainly found it a very interesting discussion. It's a hugely complex and important area. I'm not going to try and summarize all the themes, but clearly there are themes around confidentiality that are absolutely crucial. What came through, I think, very strongly is the absolutely fundamental need for patient involvement from the very beginning, whether it's around developing apps themselves and or evaluation and evidence generation. I think very interestingly, the points that have come out around transparency for trust, the issue about simply providing apps around well-being rather than those that are dealing with patients who have quite serious mental health problems, and the need, I think, for, I think it was Dan who mentioned the issue around a community of mental health developers, in a sense, who have experience of this. So in a sense, we see that there are a huge number of problems, but it's a very interesting and rapidly developing field. And I hope that this has contributed to everybody's awareness and understanding. We very much hope, I think, following these webinars, that the community of interest formed by the audience will continue to exchange, because it's very much needed. And I'd invite you all to visit the webinar website. The next webinar is going to be on the 23rd of October, when we're going to be talking about evidence for digital health. Is there a magic bullet? And we have Trish Greenhalgh and Victoria Betton. I'd like to finish by thanking not just the panel, but also all of those involved in giving us technical support, our funders from UCL and the HIN, and to wish you all a very good Wednesday. Thank you very much indeed.